Hello, everybody. Today I will be talking to you about the classical-like Ehlers-Danlos syndromes. My name is Serwet Demirdas. I'm a clinical geneticist, a doctor at the Erasmus Medical Center in Rotterdam in the Netherlands. And why I am saying that I'll be talking about syndromes in plural is because two types of classical-like EDS at this point are known. First of all, type 1, and secondly, type 2. Type 1 is caused by variants that are biallelic and lead to a loss of function in the TNXB gene. And type 2 is caused by loss of function variants in the AEBP1 gene. I will talk about the tennyson X deficiency, so type 1 at first, and secondly about ACLP deficiency, so type 2 secondly. Tennyson X deficiency is another name for the type 1 classical-like EDS. And well, it's quite self-explanatory actually, because it is caused by a deficiency of the protein tennyson X. It was first described by Professor Schalkwijk and his colleagues. He is a dermatologist in Nijmegen in the Netherlands. And they saw this patient, a male, 26 years old, who was known to have an endocrinologic problem, which is called CAH, and it is caused by variants in the CYP21B gene. And this patient had a deletion in that region where this gene is apparent. And the reason why he consulted this patient is because the patient had very hyperextensible skin and generalized joint hypermobility. And it was thought that it might be a second problem in this patient next to his endocrinological problem. And they were thinking about a type of Ehlers-Danlos syndrome. And they saw these patients, and what they thought, well, there's a deletion around the CYP21B gene, but very closely to this gene is the TNXB gene, which also was deleted. And they knew that this tennyson X had some function in the skin, and they were wondering, could it be that there's a problem there leading to this new type of Ehlers-Danlos syndrome? So they used immunoblotting to look at the patient's skin cells, and they saw that he was not making any tennyson X. They also checked the skin cells of the father and the mother, and they found that they did make TNX, but at a lower rate than controls that they also checked. So it was thought that this was a new type of EDS that was autosomal recessive in inheritance. Then it took a while, but 4 years later, they found a new family with 3 siblings who had the same EDS phenotype as this patient, namely the hyperextensible skin and the generalized hypermobility. And again, these 3 patients also were not making any tennyson X in their skin cells. And as you can see from the pedigree, it seems to be, again, autosomal recessive inheritance. So yes, they found a new type of EDS. They were absolutely right that it was also caused by a complete lack of tennyson X. And this protein is an extracellular matrix protein or a glycoprotein. We'll tell a little bit more about that later. And why did we decide to call it classical-like EDS? We decided this in 2017 because it's very much like the classical type, but there are indeed differences. The cause apparently is different. The inheritance is not autosomal dominant, but autosomal recessive. And these patients do not show any atrophic scarring. And that's very different than the patients who have classical type of EDS. And later we also found that these patients seem to have distinctive toes and feet. Well, not all of them, but some of them. And I will get into that a little bit later. It's a rarer type of the EDSs, and to date we know of 51 published cases. There are some more, but 51 are published. So what does this protein do? Tennyson X was the first extracellular matrix protein that was thought to cause EDS. And here the collagen fibrils and the extracellular matrix are portrayed. And what you can see is that tennyson X binds to collagen fibrils using decorin, a small molecule. And it also interacts with collagen 12, we know, and with collagen 6, and probably other molecules as well, but this is what we know at this point. So while interacting with those types of collagens and the fibrils, it helps maintain strength for the connective tissue. Here you see the gene. It's a large gene, 44 exons, and also the variants. Well, some of the variants that have been found in patients, and you can see that these are variants that cause frame shift, stop codons, but also missense variants, small and large deletions. When sequencing this gene, it should be all remembered that it has a pseudogene which complicates sequencing sometimes, and that gene is called TNXA. In 2017, new criteria for the Ehlers-Danlos syndromes were written down, and we also did this for the classical like EDS type 1. So the major criteria we stated are: we see in this patient skin hyperextensibility, they have a velvety skin texture, and most importantly, we did not see any atrophic scarring in these patients. They have generalized hypermobility, secondly, and of course, well, we see recurrent dislocations and other problems that we know, complications of generalized hypermobility. And then thirdly, we see in these patients that they have easy bruising from the skin and even ecchymosis. If we looked at the group of patients, the three major criteria actually we saw in all of the patients, but these minor criteria were apparent in some patients and not all of them, but they seem to be part of the phenotype, and therefore we noted them. We saw that there is partially a neurological phenotype as well in some patients with atrophy of muscles, proximal and distal muscle weakness, and also some polyneuropathy. Perhaps this has to do with tennyson X having an interaction with collagen 12 and 6, which are known to cause problems that are neurologically, as you know. And also we found interesting phenotypic differences in some of the patients when it comes to their hand, feet, and legs. So the feet and the hands, we saw that there is some redundant skin, and that especially the forefoot are broad and plump. The fingers and the toes are short. And yeah, we see also some deformities of the toes and the fingers, not in all patients, but in a few of the patients. And what we do not understand, but what we also saw mostly in female patients, is edema in the lower legs, of course, in absence of cardiac failure. We still don't know why this happens. That needs some further investigation. And also these patients have shown to also have vaginal, uterus, or rectal prolapse. Not all of them, but again, some of them. So how do you come to a diagnosis? Well, first of all three major criteria should be apparent, and you should have a family history that is compatible with autosomal recessive transmission. But you do need biallelic variants that are class 4 or class 5 to reach a final diagnosis. Now I will show you a few more of the patients that have been published for you to have a better view of the disease. So in 2001, this is the first pediatric patient that was published. And again, no atrophic scarring, but yes, a doe-like skin texture and hyperextensibility. And they showed that this child in his serum does not have any tennyson X protein. And they also looked again at the father and the mother, and when they compared to control, they saw that they made around 50% of what you would expect. So yes, the parents are carriers, and the child probably has biallelic variants. Then in 2017, we published a cohort of 17 patients, and these pictures actually present the major criteria. The hyperextensible skin is shown. The generalized hypermobility shown, but also you see the easy bruising of the skin. And here are some examples of the hands in which you see aquageric hands, you see some Malay fingers, you see a shortening of some fingers, and these are very nice examples of some of the minor criteria I just talked about. And here you can see what we mean with brachydactyly of the toes, and especially the top left corner. It's quite yeah, the brachydactyly is quite evident, and also the short feet, and especially short and broad forefeet, is evident. And this is an example of the edema we saw in 2 of our female patients. Well, what's nice is when you bring a cohort like this, other colleagues also publish cases, and this is a very nice case from 2019, a female that's 41 years old, and they show very clearly also the problems with what you can see on the feet and the hands. And again, also this patient, female, and she has edema of the lower legs. They have shown again tennyson X deficiency in the skin, and they added scoliosis in this lady, which you of course see more often in patients who are hypermobile. Our patients in England last year, they published a very nice cohort of 20 new patients. And well, first of all, they saw the same clinical characteristic as that we had published before and others. And I really love the pictures of the faces here, where you can see that the patients actually, because of the, well, maybe you can call it redundant skin, they look older than you would expect. And picture 8, you see a very clear wrinkling of the bottom of the feet. And what's very important, I think, from their paper as well, is that they emphasize that some of their patients really had gastrointestinal fragility, and that there had been also ruptures gastrointestinally. And they advise to consider this fact in your patients when doing their clinical workup, but also when thinking about giving them aspirin and NSAIDs, because diverticulitis and diverticular bleeding can be elevated because of the use of this medication. We are now looking broader together with these colleagues and also some other colleagues into which patients actually have gastrointestinal complications, severe gastrointestinal complications, and we have around 8 or 10 patients. So it seems to be definitely part of the phenotype, and it needs further investigation. Okay, so now I would like to tell you something about type 2 classical EDS type. It is caused by biallelic pathogenic variants in the AEBP1 gene. I haven't seen any patients myself, but I want to give you an overview of the 9 patients that have been published, and just to share a little bit about what exactly this disease is and how you can recognize it. The first 2 patients were actually presented in a publication by Al-Azami et al. In 2016. They looked at their patients who they thought had a type of EDS, but were never molecularly diagnosed. And they did a very wide exome sequencing. They found in these 2 siblings a homozygous frameshift variant in the AEBP1 gene. And they describe here that they have severe skin and joint laxity, also facial dysmorphisms, and the skin laxity also causes ptosis and a sagged face. And what's also quite interesting is that on a young age, osteopenia is evident in these patients, in these 2. Here is the 12-year-old girl. And I think you can appreciate from the left up figure, pictures, that she has indeed a very loose skin of the face. She looks older. It's a little bit sagged. The ptosis we cannot see here, of course. And what they show in the hand is that she is quite hypermobile. They show here the family. It's a consanguineous family, and 2 of the siblings here, they have, as I said, the AEBP1 biallelic variant. So it segregates within the family, and they've also shown that this frame shift indeed leads to exon skipping. So indeed, classical-like EDS type 2 is caused by loss of function of the ACLP protein caused by biallelic variants in the ABP1 gene. And it is called the classical-like EDS type 2 by OMIM at first, but there could be some debate about that, and it's also in the publications debated a little bit. There's not just overlap with the classical type of EDS, but also with the vascular type of EDS, the kyphoscoliotic type of EDS, and the musculoskeletal type of EDS. So it's not as clear cut to call this classical EDS type 2. If we look at what are the differences that stand out with classical type EDS, there are several, but the most important ones are, of course, the cause, the inheritance pattern again, and the fact that the skin involvement shows some type of cutis laxa as a phenotype. And well, at least half of these patients have osteopenia or porosis from a young age on. In total, as I said, 9 patients have been published. Now, if we look at the 9 patients, what stands out? I will talk a little bit more about the phenotype. So cutaneous problems are very evident. There's a hyperextensibility of the skin, but also a redundant skin. We think that elastomers might be involved. And there's also, due to this, some acrogeria, some ptosis in some of the patients. Furthermore, we see delayed wound healing. Fragility and easy bruising with atrophic scarring is very evident. And what I find interesting is that there's also thin and translucent skin, which is more something that we see in the vascular EDS type. And patients also show, just like in other types of EDS, umbilical, ventral, or herniae. Musculoskeletal, I already said the early onset osteopenia and osteoporosis is interesting in these patients, and at least 4 patients actually have osteopenia proven. 1 does not have osteopenia proven, and the other ones have not been assessed with the DEXA scanning. Generalized joint hypermobility is a problem in this patient with evident dislocations of mostly the larger joints. A lot of patients have kyphoscoliosis, and 2 have been described to have pectus excavatum. Also in these patients, just like in the type 1 classical-like EDS, we see foot deformities with pes planus, hallux valgus, but also the toe deformities. And when you look cardiovascularly at these patients, you see again the vascular EDS type similarities. There's a mitral valve prolapse and or insufficiency in some of the patients. And we also see in several patients varices at a young age. And there's even 1 male adult patient with progressive aortic root dilatation, who also needed surgery for this. The same patient also had spontaneous bowel rupture. So this is 1 patient out of 9 with these very severe complications. For the other patients, also motility problems are reported. Other interesting clinical features, several patients have both myopia and astigmatism. 3 patients have shown to have alopecia. These are adult patients. Dental involvement seems to be something that is a little bit more frequent, namely in 3 patients, and mostly it's degenerative problems. 1 female patient even lost all of her teeth before the age of 14 years. And less frequently reported, but which might also fit the connective tissue problems, is cryptorganism 2 out of 5 mils, and 1 patient had a spontaneous pneumothorax. Now, if we look at this gene, we see that most of the variants are in or downstream of the discoidine domain, and this domain is thought to play a role in connecting the ACLP protein to several different collagens. Again, this is an extracellular matrix protein. And Professor Mulfiner group is one of the groups who also took skin biopsies, and they showed, if you look at the left on the top, you see fibrils in a normal control, which are more placed closely to each other, and which don't show a lot of differences in the diameter of the collagen fibrils. Then the lower two are the patients, where you see also collagen flowers, and yeah, they are more loosely apart, and you also see differences in diameter. Then on the right, they've also looked at elastin, and you see that for the patients, the elastin composites, they are more ruffled. So there's also some elastin problems in these patients. Now, some pictures in 2018. Two adults were described, and the male on the right, who's 33 years old, he's the one with the aortic root dilatation and the bowel rupture. You can see here clearly that there is indeed redundant skin and hyperextensible skin in both of the patients, and especially on the male on the right, you can see the scarring problems, also combined with the hemosiderosis and the toe deformities. Same year, 2 more patients were described. And again, it's nice just to see what do we see in these patients. I think new here is that these 2 siblings also have arachnodactyly, as you can see in top left, A1, and in the middle, B1, and further again, the loose skin, problems with wound healing, hemosiderosis. And here you can also see prominent superficial veins in the chest region, which is more, for me, reminiscent of the vascular type of EDS. This is an Italian lady, and she was published in 2019. And I think she's 53 years old, but she could easily thought to be older because of the redundant skin. And they again show actually the same problems as I just mentioned. And these are the last 2 patients that were described in 2019. On the left, you see patient 1, age 50 years in A and B, and in E and F, he's 58 years. Now, you would think he is much older, especially in E and F, for my opinion. And there's also alopecia in this patient. And on the bottom right, K and L, this patient is a female, and she's 21 years old, and I find her interesting because she has neuromuscular problems with loss of walking ability, but she's the only one, so I'm not sure if this fits with the phenotype or not, but it definitely could be, so this needs more evaluation, I think. So I tried to give an overview for both types of classical-like EDS, and I'm open for any questions at this point.